Okay, hello everyone, and welcome to the second episode in our webinar series, New Frontiers in HoFH, Expanding Treatment Possibilities. For those who don't know me, my name is Elsie Evans, and I'm very pleased to be moderating today's conversation on behalf of FH Europe Foundation. Thank you very much for joining us, whether you are a patient, parent, clinician, researcher, or someone working to improve the care of people living with HoFH. In our first webinar, we focused very much on the importance of early diagnosis. We explored recognizing HoFH as early as possible and how that can be not just life-changing, but life-saving in many cases. But diagnosis is only the beginning of the journey. Once a child is identified, the next very human question becomes, what happens now? What can we do? What choices are available? What kind of future can this child and family begin to imagine? That is what today's session is going to be about. Over the past decade, the treatment landscape for HoFH has changed significantly. Therapies that once felt distant, even impossible, are now part of real conversations between families and healthcare teams. And we're seeing progress in medicine, prevention, genetic understanding, and how we think about long-term outcomes. But innovation is just about science moving forward. It actually needs to be more than that. It needs to be about children and families, how they can access these advances, understand them, live with them, and the benefits of everyday life. So we want to look beyond the word innovation today, and we're going to be kind of thinking about what does this mean in practice? What does it mean for child's and families starting treatment early? What does it mean for parents trying to make decisions and navigate the journey? What does it mean for healthcare professionals supporting families through the complex care? And what does it mean for the future of HoFH, not just in terms of survival, but in terms of quality of life, confidence, and hope? So I'm very fortunate to be joined today by an excellent panel that will bring the clinical expertise, the lived experience, the research insight, and practical care perspectives. And I'll be speaking to Olivia de Graaf, who's not just the FH Europe Foundation patient ambassador, but she's also from the Netherlands. She travels, she works, amazing person, and she'll tell you a bit more about her story. I'll also be speaking to Professor Derek Raal, the professor in Division of Endocrinology and Metabolism in University of Witwatersrand in South Africa, who will take us through a case study and looking at the evolution of HoFH treatment and why the future looks different today. And after that, I'll also speak to Dr. Iulia, Assistant Professor and Clinician-Scientist at McGill University Health Centre in Canada, who will speak about innovation, prevention, pediatric therapies, and the idea of an event-free future. And then we'll go on to Lucy Barton, the lipid clinic nurse specialist at Imperial College. And she's doing a really great job at helping us break the kind of through the barrier, the bridge between the clinicians and what does it actually mean in practical realities for families. A little bit of housekeeping before we get started. The session will be recorded. It will be available later on our YouTube channels. If you have any questions, please put them in the Q&A and we will try and get to as many of them as possible at the end. As always, today's discussion is educational and awareness. So please, individual treatment decisions should always be made with you and your own healthcare team. And so I will start by inviting everybody to think, how do we make sure that new possibilities in HoFH translate into real, meaningful change for children and families? And with that, I'm delighted to start the conversation off with Olivia today. So, Olivia, thank you very much for joining us. Maybe first of all, can you just introduce yourself? Tell me kind of who you are, what do you do, your favorite things?
Okay. Hi, I'm Olivia. I'm from the Netherlands and I work in a restaurant. And for the rest, I like to hang out with my friends or boyfriends. Yeah, I think that's mostly it.
Fantastic. So you have lived through the HoFH kind of treatment era, if you like. Looking back at when you were first diagnosed, can you maybe tell us first, when were you diagnosed? And compared to innovation that is being discussed today, how has the reality and managing your condition changed?
So I was diagnosed when I was like 4 years old. But I started the treatment when I was 6 because I was the youngest at that time, if I say it
Mm.
correct.
Yeah,
And yeah, that's when it started. And I had to go to the apheresis every week. So yeah, that was mostly the beginning, I think.
perfect. So when you were first diagnosed, what kind of treatments did you undergo?
Um, well, the apheresis, I had the operations for. I first had a line. I don't know if that's the correct
Yeah,
word for it.
yeah.
Um, but that like got infected, so it had to
Mhm.
take him out. And then I got my shunt in my arm. I don't know if that's the right translation for it, but
Yeah, it's a
it's like
fistula.
a
Well,
big
some people
vein.
call it a shunt. Yeah, yeah, yeah.
Yeah. And for the rest, I take medicines at home that I have to take every night. And when I was 12, there was a study for a new medicine. Um, and after that, I could come once every 4 weeks. Um, and now I go once every 2 weeks because I'm a little bit older than I was before, of course. And I want to have my cholesterol as low as possible. So now I go every 2 weeks and then once every 4 weeks for the medicine.
Okay. So things have changed a lot since when you were first diagnosed, and some of the innovations obviously changed your day-to-day reality. And we've spoken before about what that actually means beyond just the cholesterol numbers. We know that we want to keep it as low as possible. Can you share a bit about maybe the kind of emotional and the social challenges growing up with this really rigorous treatment routine, and what kept you resilient? And how did you make it easier for yourself?
So what I remember is this just pops up in my head right now when you said it. I had to go every week to the hospital when I was younger, when I was in lower school. And I remember I always had to go on Wednesday, and on Wednesday was the shortest day of school. So that's probably why I went that day. But when the teachers were having their celebrating their birthdays, it would always be on a Wednesday, and I would always miss that. So I think if I look back, then that was like the most like, well, not the most challenging thing, but like yeah, that was like, why am I not always there? Um, yeah. Sorry, I sort of forgot the question. Sorry.
That's okay. So, I mean, that for a child, that's a big thing. You're missing out on social occasions when other children are having things.
Yeah.
And what kind of things were put in place to help you kind of get through these treatment routines and to be able to work through these challenges?
I think my mom really helped with that, and my dad, of course, because I told her like, "Oh, I'm so sad that I'm missing out on all these things," and she would just, yeah, we immediately looked like, "Oh, can we go another day?" Or, um, I don't know, get you back to school faster, stuff like that. So I think that really helped. Um, yeah, and for the rest, yeah, I just try to think of it like, okay, I'm going once every week, so that's the day to sort of think about it, and for the rest, just try to be as normal as possible. Not that I'm not normal, but just try not to make it your whole life, I guess. I think that was yeah, mostly
Yeah,
it. Yeah.
yeah. We've known each other for a while, and I remember you always saying that you had two boxes. You had the box that was for the treatment day and the therapy day, and then you had the box for everything else that you were doing.
Mhm.
And for some people, that's how they manage things. Um, if you don't mind, I also remember us having a conversation about when you were a little bit older, and you and your sister both were discussing travel arrangements because you wanted to go and travel the world as we want to at a certain age. Maybe can you talk us a bit through what that meant in the two different areas, if you like, for the two different ones of you?
Yeah. So what really came with that when I was talking to her was the realization came that she could just go pack her bags and just go whenever she wanted to go or where she wanted to go. And I have to like make sure that the apheresis is there, that it will be insured, or that it was not too much to pay myself, even if that's a possibility, but that's way too much money. So that's not possible. Um, So yeah, that's like a big difference that I like sort of got, that clicked in my head, like, oh yeah, there is a difference between us. Not that's there every day, but yeah, there still is. And that was, yeah, that is a little bit hard, because she can just go and say, okay, I'm going backpacking, let's say, for half a year or for 4 months, and she wouldn't have to think about it. And yeah, for me, that's a little bit different.
I think it's one of the big highlights between siblings, although most of the time we do everything exactly the same as everything else, but it's understanding that actually at times it does impact us, whether it's education or whether it's, traveling around the world, or just everything. We have to really kind of think about it. It's not something you can just automatically go and do.
Mhm.
On a reality of access, so we've spoken about how, we're talking a lot about the kind of new frontiers, gene therapies possibly coming through, and Derek will touch on this in a little while when he talks about how it's kind of changed for HoFH. But somebody who's experienced the clinical journey like you have firsthand, what does this new wave of medicine innovation mean for you personally? And what kind of hope does it give for you for the next generation of children with HoFH?
I think it gives a lot of hope, because there is more to sort of choose from, if that's the right word.
Yeah,
Because I also had the opportunity to um, get on the medicine, but that is with a diet. But then I would just have to take a pill, and I wouldn't have to go to the apheresis anymore. Um, so there's like more, like, yeah,
freedom.
opportunity
Yeah, yeah.
to choose from. Um, so I think that's very hopeful, that there are new things coming, and yeah, that they're trying out. Um, but yeah, I think everyone needs to like look personally at what would work for me, and how can I just live my life without having to think about it 24/7. And yeah, I think that, yeah.
That's it. I think, we're always talking about the hope that it brings, and the fact that I think the majority of us who live with homozygous FH generally don't really want to think it 24/7. So we quite often kind of put it to the side, and have to only think about it when it gets really serious. But you've also met a lot of the other ambassadors, and you know that there are massive barriers and challenges to actually access some of these. From a patient perspective, what does it feel like knowing that there's these life-changing treatments that exist, but that it possibly just out of reach because of healthcare systems or geographic where you live might be an issue?
Yeah, if I start thinking about it, then I will cry, I think, because I just, yeah, in my head, I just can't understand why they wouldn't try to sort of, well, not save them, because that would sound so bad, but yeah, like, why wouldn't, if there's treatment, why wouldn't you give it to someone? So I don't know, I feel a little privileged that I do get it in the Netherlands, that it's sort of better there, that they know what they're talking about, and like they will get you through every step. Um, and I just really hope that, yeah, that also happens in other countries, because they also deserve to have like a more peaceful life in that way.
It is.
Yeah.
I think it's great that all of us can kind of get together and chat, but I think it is one of our hardest things to work through, is the fact that some of us have access to treatments. But to be fair, even in privileged countries where the treatments are available, it doesn't mean you automatically get them, because as we know that, there's a lot of barriers with healthcare providers and having to go through all of that. So yes, absolutely agree with you that a future where that shouldn't be a barrier will be extremely welcome as we go forward. So we will get onto more things in a little while, but let's say a family has just been diagnosed, their child has just been diagnosed and is scared or terrified of starting these new treatments. What is the single most important piece of advice or encouragement that you would give either the child, if they're old enough to understand, or the parents, or both?
Um, that's a hard one, because I would say, from my perspective, trust the doctors. They know what they're talking about, but that's from my perspective. So I don't, I know that it's in other countries it's a little bit different, and they say different things to you that don't even make sense. But yeah, I would just say like just like try the things. Sorry.
No, it's fine.
Yeah.
It is very different when you have doctors or a team that you can trust, and I think that is sometimes the biggest issue that we face is finding that team that will support you and support your personal decisions. And we've experienced that with both of our journeys, where sometimes it's really difficult to find that. If you could change one thing in this kind of whole thing, because we're specifically talking about early detection and finding individuals as early as possible and treating them, especially now with the situation where you have to go back to apheresis bi-weekly because we need to keep the levels low. What would you, if there's one thing that you could change for children maybe being diagnosed, what would that be?
That they would just start I don't know. Sorry. No, but okay, so I think maybe because I know a girl in the Netherlands, and she started very young. She started younger than that I was, and she had a lot of trouble. So maybe you do need to start young. I don't want to say don't start so young, but maybe start not too young, because then I know she had a really hard life, and she did have the opportunity to get all the medication and stuff like that, but it was still very hard. So I think, like keep it simple.
Yeah. I think it is very hard, and I know that we have therapies available for younger children now, and maybe rather than not starting young, maybe we need to work on how do we support them to be able to manage these regimes at a younger age. But that is incredible, and thank you for sharing. I know we didn't get into your whole story and all of your kind of treatment therapies, and we have quite a few, but we will come back with some more questions after Derek's presentation. And if you have anything more that you want to add, please do, and we'll carry on from there. But for now, I'm going to hand over to Professor Derek Raal from Witwatersrand. So Derek, if you wouldn't mind, he's going to present a case study for us and how the treatments have changed. Thank you.
Great.
In the meantime, while we're waiting for her to share it, you are going to chat to us about how things have changed. And so Derek, if you don't mind, I'll say that, we've known each other for a long time. And you were one of my first clinicians. So how has things changed from when I was diagnosed and there wasn't really any options to kind of where we are now?
Yeah, well, as you say, Elsie, you were I remember you as a very young person when you were still living in Johannesburg. And at that time, that was prior to 1990, we didn't even have statins available for the treatment of homozygous familial hypercholesterolemia. So we had really very little to offer. But it's just been remarkable over the last sort of 3 decades how things have advanced. And it's, as we've just been discussing, as you've been discussing, it's just really the problem now is just access to these very novel therapies, which have just been remarkable for the management of homozygous familial hypercholesterolemia.
So one of the other things that have changed, as you said, obviously statins and ezetimibe is the thing that most people think of when they are starting. And how old would children generally be, or what age did you used to start it from, and what age would you start it from now?
We actually start treatment from diagnosis. So in our young patients, we would start, if you definitely make a diagnosis of homozygous FH, even if the patient is extremely young. I mean, the youngest patients we've started treatment has been less than 1 year old. I think she was about 6 months old. Mm-hmm. And we were concerned that how would the young child be able to swallow a statin and an ezetimibe tablet? and we suggested to the parents they should just crush the tablets, maybe put it in with yogurt or something like that. But, children can eat sweets, okay? And this little young girl just sort of said, well, I'll just swallow it, and there was absolutely no problem. So even from a very young, and I think what's extremely important is the younger we start, the better in terms of getting to try and reduce the LDL cholesterol burden over time. Many patients with homozygous FH only start treatment in their teens or even later, and by then they've had an exposure to a lot of excess LDL cholesterol, and it's very difficult to reverse those problems once they've sort of occurred. So definitely the younger we can start, the better. Yeah.
And I know that in your presentation, you spoke about the kind of pack years and how important it is to start at an early age. And obviously, the younger we start, what kind of difference does that make in life expectancy, if you like, for homozygous as general?
Well, I think the earlier we start, the lower that we can reduce that age, definitely the longer. I have one homozygous patient, and we've recently celebrated her 81st birthday. So that's remarkable what we can do these days. Yeah. Okay, so I'm just going to really talking about expanding treatment possibilities for the treatment of homozygous FH. So we must just remember that familial hypercholesterolemia is one of the commonest genetic disorders worldwide. We tend to forget that the single dose, that's heterozygous FH, affects 1 in 300 people. So people with heterozygous FH have LDL cholesterols about twice normal, but because of that increased exposure, they develop coronary heart disease, often in between the age of 30 and 60. Fortunately, we have very good drugs now available for treating patients with heterozygous FH. But today we're really concentrating on homozygous FH, which is much less prevalent. It probably affects about 1 in every 300,000 people worldwide. LDL cholesterols are over 4 times normal. And because of these very high levels, coronary artery disease occurs in childhood. The youngest patient I've seen was only 1 year old when she had a heart attack. And one of the problems with homozygous FH is poor response to current therapies. So this is just a cartoon showing the problem. In a normal person, they have lots of what we call LDL receptors. Those are receptors on the cell surface, and you can take up cholesterol. If you're a heterozygous patient, you have half the number and can only take up less cholesterol. And the big problem in homozygous FH, you have very few or no what we call LDL receptors on the cell, and you cannot take up cholesterol. So if you look at it another way, by the age of 80, if your LDL cholesterol's been 3 your whole life, your arteries would have been exposed to about 240 cholesterol years. In a homozygous patient whose LDL cholesterol is 4 times normal, at the age of 20, their arteries are already 80 years old. And that's why it's so important to start treatment early. So I'm just going to present a case, and she actually may even be listening online. It's a 16-year-old female who presented with these little yellow lumps and bumps over her elbows and buttocks, and a fasting lipid profile was done. And as you can see, a very high LDL cholesterol and total cholesterol level. This is just a picture of the typical lumps and bumps we see. If anybody has these cholesterol deposits between the fingers and between the thumb and the first finger, that's virtually diagnostic of homozygous familial hypercholesterolemia. So as I mentioned, there's a number of therapies. I'm just going to go through the newer therapies, the lipid-lowering therapies, say a little bit about LDL apheresis, and then just end off with talking about what's new, and that is gene therapy, which is coming now to the forefront. So when we talk about the treatments and the drugs available, we talk about drugs that are dependent on those little receptors on the cell surface. And then there's the newer therapies that are independent of the LDL receptor, and that's very important in homozygous FH. So do statins work in homozygous FH? And this is very old data from way back in 2008 when we first started using statins in our homozygous patients. And Elsie, you would have been one of those sort of patients. And the bottom line is statins do work in homozygous FH, but they're about half as effective. So instead of a 50% reduction, we get about a 20 to 25% reduction in LDL cholesterol in patients with homozygous FH. But importantly, we looked at before statins and after statins. Before we had statins available in our cohort in South Africa, the average age of death was 18. Just by taking statins, which only reduced the LDL cholesterol in the order of 20 to 25%, we doubled the lifespan to 32. That's just shown another way here. So just with statins, we could improve the lifespan of patients with homozygous familial hypercholesterolemia. We mustn't forget about the drug ezetimibe, and this is data from patients with homozygous FH. If you add ezetimibe to a statin, you can get a further 20% or so reduction in LDL cholesterol. So in our young patient, we started with a top dose of atorvastatin and we added ezetimibe, and you can see there was an improvement in the lipid profile. The LDL cholesterol came down to 8.8, but naturally that's still too high. So what can we do in addition? That's our standard therapy, and we start with statins and ezetimibe at diagnosis in a patient with homozygous familial hypercholesterolemia. But what about the newer therapies that are becoming available, and I've listed them here. I'm going to just talk about them in turn. First, what about the PCSK9 inhibitors? Now, these are drugs that work by upregulating the LDL receptor. So would they work in patients with homozygous FH? And very similar to statins, the PCSK9 inhibitors are about a half as effective. So as shown in the little diagram in the bottom right, in a heterozygous patient, you can reduce the LDL a further 60%. But in homozygous patients shown in blue, the effect is about half, so about a 30% reduction. But still, that's of great value in a patient with homozygous familial hypercholesterolemia. So we added a PCSK9 inhibitor, and you can see there was a further reduction in LDL cholesterol down to 6.2, but naturally that's still too high. So what can we do next? And that's when these newer therapies are becoming available to us and are very important for the management of patients with HoFH. There was a drug called mipamursin, no longer available. I'm just going to talk about the current drugs, that's lamiptalide, and a drug called evinacumab. So what is lamiptalide? So this is a drug that prevents the formation of VLDL, very low density lipoprotein, in the liver, and LDL is made from VLDL. So if you're unable to make VLDL, you do not make LDL. So this is just the efficacy of this drug called lamiptalide in homozygous patients. You can see we can reduce LDL cholesterol by about another 50%. Because VLDL contains lipid, that remains in the liver. So a side effect of this therapy is that you can get a bit of fat accumulation in the liver. And also, you do get gastrointestinal side effects because you don't absorb the fat as well. But if you can get tolerant of this therapy, starting with very low doses, increasing the dose, you can get a very good reduction of about 50% in patients with homozygous FH. The newer drug, which is called an ANGPTL3 inhibitor, a drug called evinacumab, which is given as a monthly infusion. So a little drip is put up, and this is given by infusion. This was the outcome study we did in 65 patients with homozygous FH, and compared to placebo, this therapy reduced LDL cholesterol by a further 50% and is extremely well tolerated. Importantly, it didn't depend if you had HoFH with no receptors, what we call null shown in red, or with some LDL receptor function shown in blue. So it really shows that this therapy is totally independent of the LDL receptor. In the longer term, this is long-term data, the reduction in LDL cholesterol is maintained. This is a large study, 116 HoFH patients, and over a prolonged period of more than 3 years, the reduction in LDL is maintained for of a 50% further reduction. So it begs the question, if we put all these therapies together, will we be able to prevent the development of atherosclerosis in HoFH? And there have been some studies to show marked plaque regression. I will just show one example. This is one of our patients, a 25-year-old girl, and after a year of therapy with statin, ezetimibe, and ANGPTL3 inhibition, evinacumab, you can see over a year period there was marked regression of these xanthomas over her hands. So our patient fortunately was also allowed to get this therapy, and we managed to get her LDL cholesterol down to a level of 2.2. So if you look at her period from starting with an LDL of 14, statins did work, ezetimibe also helped, the addition of a PCSK9 inhibitor, and finally evinacumab reduced the LDL cholesterol levels to near normal, to a level of 2.2 millimoles per liter. So this is just a summary of the different drugs. Statins, ezetimibe, PCSK9 inhibitors are dependent on LDL receptor function, but they can be tried and should be tried in homozygous patients. If you do not get to target, we've got to use the newer therapies, lamivudine and evinacumab. Unfortunately, these therapies are not available in many parts of the world, particularly in third world countries. So there is still a very important place for lipoprotein apheresis. That is given once every week or once every 2 weeks. We filter LDL cholesterol out of the bloodstream. The disadvantages are, as was mentioned at the beginning, is access. You often need a shunt, and unfortunately this doesn't restore LDL receptor function, so it needs to be repeated every week or every 2 weeks. But it is effective, and it will also reduce LDL cholesterol by 40 to 50% if given weekly or fortnightly. And then just lastly, what is new and what is under development? I mean, the problem is abnormal or low LDL receptor function within the liver. So we can naturally replace the liver. We can do a liver transplant, but I think that is end resort, because there are surgical complications, and unfortunately, because it's not your liver, so another liver's been transplanted, is you need lifelong immunosuppressive therapy to prevent rejecting the liver. So what is really coming in the future is possibly gene editing. In other words, you don't need to do a liver transplant, you edit the gene, and you edit either PCSK9 or ANGPTL3. So there's then no longer a need for daily therapies or for monthly infusions of an ANGPTL3 inhibitor. Maybe we can do it by editing the gene within the liver. And this is just an example. This is a drug called VERVE-101, which edits PCSK9. That will not be enough in a homozygous patients. But studies are now being done also with editing ANGPTL3. So instead of needing a monthly infusion of evinacumab, maybe we can edit the gene, knock out ANGPTL3, and that would be like then replace the monthly need for an infusion. So have we found a cure for homozygous FH? And this is just some words from Gil Thompson. Like the conquest of Mount Everest, overcoming the challenges of FH, particularly homozygous FH, has been a long and difficult endeavor. But I think with these newer drugs that have now become available, and now in the future gene therapy, I hope we will be able to find a cure for this condition. What I think is important is that the majority of heterozygous patients and all homozygous children and adolescents require lipid-lowering therapy in order to reduce their lifelong burden and to delay the onset of atherosclerotic cardiovascular disease. We have now effective therapies, but we need to start much earlier We need to get the LDL cholesterol as low as possible and for as long as possible. And I think if we can do that, we're going to improve the lives of our patients with homozygous familial hypercholesterolemia. So I'll end there.
Thank you very much. That was really good. And it's great to hear from somebody, because you have been around long enough to see all of these changes and how things are developing. So thank you very much, Professor. And we will catch up in a minute with some more questions. But I'd like to now ask Iulia, if you would like to kind of join us. And I'm going to ask you some questions specifically around pediatric therapies and early intervention. We are seeing a move with the cardiovascular prevention plan, the Safe Hearts plan, the significance of recently approved pediatric therapies. From a clinical standpoint, how drastically does the trajectory of HoFH change when you intervene in early childhood versus delaying it until even adolescence? And what does this shifting timeline mean for preventing that cumulative buildup of cardiovascular damage?
Thanks. Thanks, Elsie. So this is a very important question. I think it really changes the trajectory quite significantly. So in HoFH, the cardiovascular clock, like Dr. Raal mentioned, really starts at birth. So very, very early on. So the children are exposed to extremely high cholesterol levels from the beginning of life. And then the complication we worry about, the heart attacks, the aortic valve disease, they can begin very early. So if we wait until children become teenagers or adolescents, then we're already treating after many, many years of cumulative LDL cholesterol exposures. So the treatment as early as possible is extremely important to really prevent establishing the heart disease, the coronary disease. So that would be my answer, to really try to intervene early in childhood, so that to decrease and flatten this LDL cholesterol exposure, I would say, and prevent this vascular damage.
We know that this is a very important part, and all of the documentation shows that now. We've seen in the guidelines, the EAS guidelines that were released, that obviously earlier detection is a big thing, earlier treatment is a big thing, quite aggressive treatment is also mentioned, specifically for homozygous FH. While starting advanced therapies early will offer a massive clinical benefit, we're not disputing that. And the Child's Cardiovascular Prevention Plan obviously will benefit tremendously. It also introduces a medical regime that at a very young age can be quite tricky to balance between how aggressively you treat and the early prevention of medicine, but how also to protect their everyday quality of life. How will it fit in? How would you support a family or the patient if they are able to already kind of understand their decisions themselves through this journey?
Yes, I think this is definitely a balance. So you need to have balance about being in a way a bit aggressive about prevention, but gentle at the same time, and quite thoughtful about this implementation. So the goal is not really to medicalize the child's entire life, but the goal is really to prevent HoFH from taking away their future, right? So I would really approach this first of all with a shared decision making between everyone, and especially the families. So I explain to families whenever I have a child and their parents why early treatment matters. But then I also ask them, what's important for them. I tell them about the appointments, to reassure them that there's, whether there's a burden or not. Do they have needle fears, for example? We talk about school, about travel, about the diet, the sleep. So I think you really have to take it as a whole. So I think the most important plan is a plan that the family and especially the child can sustain over the years, and then simplifying it as much as we can, and coordinating care with everyone and supporting them, and making sure the child just lives a normal life.
I definitely agree with that. That's I think it's something that we all thrive for, is to look at things as a whole rather than individual pots that we're trying to fix. And Lucy and I will be discussing a bit more about how we can kind of do that in a practical fashion in a minute. we've discussed the concept of event-free future, if you like. So historically, event-free future for HoFH simply meant keeping the patient alive. You know, that if you can live longer, then it's all good. That's fine. But with modern innovations on the horizon, just exactly that you were just talking about, looking at it as a whole, how are you redefining what an event is? And are we aiming for just preventing the clinical blockages, or are we looking at normalizing a person's life expectancy and lifestyle?
Yeah, so I think you said it very nicely. So yeah, like you said before, the event-free future really meant preventing a heart attack or a stroke. But I think today, with all the treatments that Dr. Raal presented, I think we can be a bit more ambitious. So of course, we still have to prevent a heart attack, the stroke, the progressive aortic disease as well, and the premature death. But for a child, this event-free should also mean preventing this silent progression of disease. So preserving the normal childhood and his teenage years as well. So to me, an event-free future, in a way, it might sound a bit cliche, but it's really where the child grows as normally as possible, goes to school, has a normal life, participates in life in the normal activities, and transitions to adult care without actually having homozygous FH dominate everything. So the treatment dominate everything. So to try to normalize it as much as possible while treating him as early as possible. I think that's the direction that we should be aiming for.
I think it's very clear, even from the conversation I had with Olivia, that, we want to make it as easy that it fits in to lifestyle without it burdening the individual. But at the same time, we understand the necessity from what Derek presented about how important it is to start early. So you are specifically kind of addressing what needs to happen to ensure innovation reaches the patients that need the most. We know that these things are available. As a clinician and scientist, how frustrating is it to have all of these groundbreaking science-backed pediatric therapies available on paper, but knowing that health economics, geography, where you live, could prevent patients from accessing them? And is there something that the medical community can do as a responsibility to help solve this?
Yeah, so it can be frustrating. Don't get me wrong. You mentioned innovation, so having access to innovation, yes, it is necessary, but I think it's not necessarily enough all the time. So I think a therapy changes the outcomes of a patient if the child can actually access it early enough. So for this, I think we need several things. So first of all, the awareness, so that the child is diagnosed earlier, the screening as well. So cascade screening is extremely important. When I have families, I make sure that the child, the siblings, the grandparents, everyone in the family gets screened, and then genetic testing, where available, should be done, and really having this clear referral pathway, having a multidisciplinary team following. Also, what can help, and Dr. Raal mentioned, and also with the European Atherosclerosis Society, have different registries or real world data to study this, how the patients are doing, because HoFH still remains underdiagnosed, undertreated. So I would say that the progress is this innovation has to be translated into earlier diagnosis, treatment, and access to as many as possible.
I think we all agree that the access for everybody shouldn't be a barrier to people kind of getting things. And I'll definitely come back to Derek with a couple of questions on that access as well, because we all live in different areas, and we know that makes a big difference to what we can access and how we work through that. I appreciate your time, and I will definitely have some more questions on the panel. But for right now, I'd like to also now move from that understanding the barriers and the challenges that everybody faces to Lucy. So Lucy, thank you very much for joining us. And I'm very proud to say I think it's the first time we have a lipid nurse actually on the panel, which means it's a nice way to bridge that gap between kind of clinicians and patients, because as much as we deal a lot with clinicians, at the end of the day, when it comes to practically putting things in place, quite often that falls down to you guys. So I'd like to kind of first touch on last week's webinar, which focused very much on the urgency of early diagnosis. Once the family kind of gets that diagnosis, or there's a suspicion, and they suddenly kind of thrust into this world of complex medical meetings and having to, come to all of these different appointments, in your experience with families, what are the immediate practical realities and hidden treatment burdens that families struggle with most?
First of all, thank you for having me. I mean, that the question you just asked is really a good question. In my experience, once the diagnosis is confirmed, families are often faced with very practical challenges, including starting the treatment, organizing the blood test, and fitting in long-term follow-up into everyday life. For a child who feels completely well, that shift can be quite hard to process. But however, in my view, the biggest burden is often the emotion side. I have seen so many parents experience a sense of guilt because it is an inherited condition, even if they don't express directly, but you can just say from the way they acted, the expression, you just feel this is something. So as frontline healthcare care providers, we need to be very mindful of how we communicate, offering reassurance and avoiding any sense of blame. This is the kind of the first line normally we want to apply, and in those first few months, it's not just about starting treatment. It's about supporting the whole family and setting expectations and help them adjust both practically and emotionally.
It's a very important part, because you guys quite often hear the stories that the doctors won't hear, because it's you spend more time with us, whether it's taking blood or trying to work us through documents. With the kind of newer advanced therapies that was discussed by Iulia and by Derek, the treatment landscape is expanding. Does this kind of change of new options ease the day-to-day treatment burden of families, or does managing these multiple therapies introduce a different type of logistical complexity for them?
I don't think there's a straightforward answer. On one hand, these new therapies are incredibly positive. They offer better lipid control and real hope for improved outcomes, especially if adherence is good. But in reality, they also introduce new challenges. Some treatments are quite demanding. For example, avanicumab requires monthly infusions, and lomidopide comes with strict dietary requirements. So while we improve the effectiveness of the treatment, we may also be adding logistic and lifestyle complexity. So in my view, it's really about the balance. The expanding options are a big step forward, but they make it even more important to individualize care and support family in a way that fits into their daily routines, their daily life.
Mm-hmm. So on that kind of trying to support families, what can patient organizations do to support them? Is there a place for that?
Normally we give out the information to whatever. So in the UK, as you know, it's kind of the Heart UK website, and then there's FHEF Europe now, and also there's British Heart Foundation. So it's quite, for UK, it's the patients have a means to access resources. So it's quite easy for us to introduce all this information, but I do understand across the world things may differ.
Mm-hmm. It is. It's very important, and we can
Yeah.
try and make it as easy as possible to share the information as well. I have a question, because you are the apheresis nurse for myself, so I've seen it regularly. So we know apheresis works. We're not disputing that, but we also know that it is quite invasive, and regular injections with some of the new treatments is also invasive. But these are cornerstone treatments. Needle anxiety is something that actually Iulia just touched on as well. And in our previous webinar trilogy, we also had a conversation about it. And it comes across as quite a minor hurdle for some. It's like, well, how complicated can it be? But it is a massive barrier to adherence. And it's not just children. I know that you work with young adults at the apheresis center. How can we support children and parents to transform into this highly stressful clinical experience that can be quite traumatic? How can we manage that in a way that it's less traumatic, less disruptive, and supports long-term compliance?
I think, yeah, as you mentioned, I think we can all agree that reducing non-adherences around the invasive treatment like apheresis and the invasive injections is one of the biggest challenges, and there's no simple solution. Based on my experience, what really helps is taking what I call is a child and family-centered approach. For example, for children, we try to reduce fear step by step using simple explanations, preparation, and sometimes distraction techniques, so that the experience feel more predictable and less intimidating. Even small things like allowing the choice and give the child a sense of control can make a big difference. We can also focus heavily on education and reassurance for parents, because their anxiety can often transfer to the child. Supporting them helps supporting the child. Importantly, as we already touched, we also create a strong support system, so families know they are not dealing with this alone. Ultimately, you're right. If we can make those early experiences feel safe and manageable rather than overwhelming, we're much more likely to maintain long-term compliance.
It makes a big difference, I think. And so specifically on this, we've got this new frontier of HoFH care. The dynamics between patient and clinicians are evolving into a more co-sharing or co-decision-making situation. And this goes beyond just prescribing the right medication for the right person at the right time, which is ideally what should happen. What do families truly need most from their teams or their healthcare teams today to feel genuinely supported and empowered and safe to be able to have this conversation?
I think beyond the prescribing the right treatment, what family really need is to feel they're being heard, supported, and reassured. This is a lifelong condition. It can feel overwhelming, especially at the beginning, as we mentioned. A big part of our role is communication. Taking the time to explain things clearly and setting realistic expectations and being open, approachable, so families feel comfortable asking questions. Families also need consistency and continuity, I think, knowing there's a team they can rely on and knowing where to go if they have concerns. And that sense of a safety net is really important. Essentially, it is all about empowerment, helping family feel confident in managing the condition and making informed choice rather than feeling as though it is something being done to them. So I think for me, good care isn't just about the medication. It's really about building trust and partnership and working closely with families so they feel confident managing this lifelong condition over time.
That's brilliant. Thank you very much for your time, Lucy. And as much as I'd like to go to all of these questions that we have, unfortunately, we are kind of running short on time. So one of the things is, Olivia, what advice would you give a child, kind of young person just moving into transition into adulthood, when they have to start taking on responsibility for their own care?
What advice we have? The advice that I'm giving now. Okay, so I'll be short because we don't have a lot of time. Listen to your doctor, because when she told me that I had to come more instead of once every 4 weeks, once every 2 weeks, I was like, and who decided this? And my cholesterol is low enough, and someone who doesn't even have it, they decided that it had to be lower. And then she told me that's actually not the case. It's just for your own health and for your own future that we want to have you more. If that's that's what it makes sense.
Yeah.
So yeah, I think it will be just trust them and don't be like, yeah.
I think it's actually a good point to stop on, because I can guarantee you that at some point we all do that, and that target has changed from when I was diagnosed. I think we were happy to get it under 10. Now somebody else in this panel is trying to get me to get it under 1.8. which, you know, it's tricky. So I think on that point, that is the best piece of advice we can give, is that, yes, sometimes growling is not a good idea. Take a minute, take a breath, and let's get back to that. We've all said that communication, that trust, and doing something together rather than to the person, can we make those decisions together? I want to thank so much all of the speakers, Olivia, Derek, Iulia, and Lucy, for sharing the insights that you did. Thank you to everybody who joined us and contributed questions. I appreciate we didn't get to all of the questions, and I will promise to try and get as many of these to the experts and share with you any of the answers that they've got. I would like to thank our rebel partners, European Atherosclerosis Society, EAS, and IAS, International Atherosclerosis Society, for supporting the webinar series and for supporting us as an organization to be able to bring these to you. Also, the Allies of the Force, Chiesi and Ultragenics, your support makes the mission possible as well. So thank you very much. I also would like to say that next week we have Living with HoFH Reality through the lens of children, parents, and siblings, with an amazing panel and looking at the psychological aspect and how to kind of manage that as well. So please, it'll be great to see you there as well. Again, thank you very much to all of the guys on the panel, and any questions that has come through, we will follow up with the email from the team behind, who was incredible at trying to sort out the technical side as well. Thank you very much for everybody.
Thank you all. Bye.
Thank you.